All right, can everyone see this?
Yes.
Okay. So, I mean, you all know what sickle cell disease is. It's a chronic disease that's inherited. So patients have it since birth, and we actually identify it on newborn screening now in the, in the United States. And it's a one gene mutation that causes the presence of hemoglobin S, or sickle protein, sickle hemoglobin. And that's the pathophysiology of sickle cell disease, just this one gene mutation. And with the hemoglobin S, when it polymerizes, that's what causes sickling and causes the rigidity of the red cells, which then causes a vaso-occlusive crisis. Now, it's more than just a red blood cell disease, because it's a cycle that goes on since birth, all throughout their life, whereby they sickle, which then can cause vaso-occlusion and then cause vascular damage. So it's not just red blood cell disorder, but also a vasculopathy. And then that vasculopathy causes sterile inflammation, whereby all these white cells come on, causes more cytokine release and pain and damage to the endothelial cells. And the same effect that sickling then causes reduction of lifespan of the red cells by hemolysis, and the heme that's released is also toxic to the endothelial cells. The cell-free hemoglobin, which then causes more vasoconstriction and contributes to this vaso-obstruction. And this cycle goes on and on and on. And we know that there are some triggers. So we know that fever, infection, dehydration can definitely affect the sickling process, and stress can definitely increase pain as well. And there was a study that looked at mental stress, fear, anxiety, and this, I won't go in detail, but it affects the autonomic nerve system, which then also can cause some vasoconstriction, which affects the blood flow and then causes sickling to occur in these patients. So we see these in our patients whereby, they seem to be okay, and then some stress affects them, or anxiety, and then they appear to be going into crisis. Because of the vasculopathy, sometimes these crises can be a pattern whereby they know, oh, okay, this is the side that I always get pain, or this is the leg that I always get pain, because there's already been some damage there, almost like a hemophiliac who's had like a target joint, if that joint has had bleeding in the past, then it can be recurrent. But a lot of time it happens anywhere. And I don't have that on this presentation, but if you imagine, blood flow goes everywhere in your body, so you can have a obstruction of blood flow anywhere. So we're talking a stroke that can happen in a 2-year-old, retinopathy, acute chest syndrome, whereby the lungs not getting enough oxygen and going into crisis that way. Muscle joints are common, back pain are very common. Over time, it causes avascular necrosis of the joints, or just bony infarcts causing osteoporosis and osteopenia, which then can cause kind of minor damage to the bone itself. So the pain can be very unpredictable, but what we know is usually in childhood, it's more of an acute focal pain, because I guess the organ damage hasn't quite occurred yet. So a lot of times they come in with acute crisis, they go in the hospital or come to our clinic, get IV fluid, get IV pain medication, and usually they may need something stronger than just Aleve. We usually give some morphine with some Toradol, because it's almost like having, if you understand the pain that they go through when someone has a heart attack, when you're not getting oxygen to your organ, to your muscles, that is what they're experiencing in other parts of their body. And in some people with sickle cell, they say that they've experienced a fracture, and their pain that they experience is sometimes worse than having a fracture. That's how bad it can be. But because it is something that can recur over time, they have different coping mechanisms. I find a lot of our patients go into depression because they say, when I say I'm in pain and I've learned to cope with it, and my coping mechanism is I kind of keep it inside. They say, there's no point in crying because no one does anything. Or if I say I'm in pain, everyone says, just do this, just do that. And so by the time they get into adulthood and they go to the ER, a lot of time they look at these patients and they say, oh, you look fine, you're not having a fracture, you're not having something, but they're asking for pretty high doses of opioids because, over the years, they've become somewhat tolerant to the smaller doses. So if you start off at, I don't know, age 4 years old, and I'm giving them morphine, 1 milligram, 2 milligrams, by the time they're 21, they need 6 milligrams or 8 milligrams of IV morphine to really get that pain under control. And what we do understand is that when there's acute pain, you want to try to hit it hard, because what our patients have gone through, it's almost like a stress syndrome, PTSD, because they know that, okay, I'm having pain, it's triggering this anxiety that, okay, this pain is going to get worse and worse. No one's going to listen to me. And it just goes into that cycle. And if you don't hit it hard quickly, then it lingers, and they just get, the next time they have pain, they just have the anxiety of trying to get relief, knowing that there's going to be delay, and then the anxiety and things like that. A lot of them, by the time they're in their early 20s, they have a lot of anxiety, depression, stress, because it's affected their lifestyle. They've missed school, they're not doing that well in school, they have very poor coping mechanism. Family dynamics play an important role. I do see if there's a lot of family support, a lot of our patients do better. But unfortunately, a lot of our patients have very dysfunctional family already. And then you have a parent that can either be overbearing mother who's always worried about this child, and a child that's then reacting against that, right? Because now you're a teenager and like, I want to be my own person and not have mom control everything. So it is a very difficult situation. So I feel you, because even after doing this for almost 20 years, I still can't tell when a patient is truly, truly in pain or is manipulating and wanting to get more pain medications. But what we always say is trust the patient, because if you look at the sickle cell disease iceberg of pain, and this was done by Smith, the pain specialist will probably know this, they're looking at utilization with and without crisis. Utilization meaning, going to a provider's clinic or to the ER. Only about 45% of people actually live without pain. Most of them have some pain all the time. And it's just different degree of pain that they go through. And even with crisis, a lot of them don't like going to the ER because they don't like to wait. They don't like the stigma that is associated with them. So most of them try their best to control this at home until it gets so bad that by the time they get to the ER, it's like the worst thing for them. We try to see them here in clinic when we're open, obviously. But obviously in the evening, I have to direct them to the emergency room. And then only about 3.5% of our patients, just that tip of the iceberg, actually request to go to the ER. Sometimes it might not be, when they appear, that it might not be that bad, but what they're thinking sometimes is that I don't want to wait till it's so severe and I have to wait so long, because you know how ER wait time can sometimes be. So they might just have that feeling, oh, I'm going to be in a crisis, I need to go to the ER now. And then once they get some fluids, they get some pain meds, they're like, okay, I feel a bit better, I want to go home. Because the last thing most of them anyway, want to be is in the hospital. So I don't know if that answers your question, but it's a very, very difficult question. But as a pediatric hematologist or a hematologist in general for sickle cell, we always say trust the patient. I have the advantage of knowing my patients for a long time because I usually see them since birth. I get referred the newborn, so I learn their patterns, know what to trust. And majority, even the ones that what we call the frequent flyers in the hospital, really don't want to be there, but unfortunately, they have other issues where we haven't been able to control their sickle cell itself. Now, obviously, once you get to all this damage, it's really hard to control once they have chronic pain and hyperalgia and sleep disorders. And what we're hoping to do is, since birth, try to control the sickling itself. Hydroxyurea is a medication that can reduce the risk of sickling. It was approved for sickle cell. It's a chemotherapy agent that was used to treat leukemia in the past. But what we found was by giving a lower dose in sickle cell anemia, it stresses the bone marrow so that they make red blood cell with slightly higher fetal hemoglobin. And that kind of dilutes the amount of sickle hemoglobin in their red cells. So it prevents sickling from happening. It doesn't prevent it 100%, obviously. But now we're actually prescribing it to 9-month-old, and I prescribe it to teenagers who hasn't been on it yet. Some people don't like how it feels because it is, again, a chemotherapy agent, so they can feel nauseous with it. Sometimes they feel a little funny. Although they can't describe to me exactly how they feel, so they come off it on their own. But nowadays, there are newer medications. There's voxelotor or Oxbryta, which inhibits sickling process by slightly increasing the oxygen level in the red cells. And then there's FDA-approved Adakveo or crizanlizumab, which is an I'm blanking on what that is. It's an antibody that prevents the stickiness of the cells when it's sickling to the vessel wall. So hopefully it allows the blood flow to continue even when they're having a crisis so that they don't have severe pain. So it feels, I just feel like this child hasn't had good hematology care to where she's at this point. But then again, that family dynamics is very difficult if she's not getting the support from her mother. I mean, she's only a teenager, and this is the time when she needs that transition, this transition period where she actually needs more care than less care. Anyway, that's my 2 cents.
That was really helpful.
Thank you.
Yeah,
And that was one of the things the mom had talked about, the fact that she might be moving to where her family is because she needs more help with the kids. I don't remember, there might have been another one that was a sickler, or if not, they had some variation. So I think mom was saying she's out here by herself, that she can't do it anymore.
Okay. All right, I'm so sorry, I have to go. Thank you for
Thank you so
much,
Dr. Rashid, for being here and giving us some inputs regarding the case. We really appreciate it.
I am actually going to be up in Reno next week. I'm giving a talk for the medication voxelotor, Oxbryta, and sickle cell. So if any of you are interested, I can email the flyer, and I'd love to meet you guys in Reno. We do go to Reno once a month because I'm also part of the HTC, so we have a federally funded hemophilia thrombosis center in Reno that we see patients once a month. But I'll email it to you, and you can email to anyone who's interested. Okay.
Yeah, you can email it to Troy, then he will get it to everybody.
Okay. Thanks a lot.
Thank you. Thank you.
Thank you.
So I will open it up for recommendations from the rest of the group here. I know Dr. Rashid gave her recommendations, which was great. But if anybody else has anything to add, please add your recommendations now to Dr. Harding.
This is Mordechai. I'm an internist and geriatrician. Though, I'm not sure Dr. Harding specifically said this, but, she mentioned that she gives hydroxyurea to people that are 9 months old. And so I know that in my practice, I've started hydroxyurea on patients with sickle cell as they're waiting to go see a hematologist and just kind of monitoring for some of those common side effects after you start it, checking their CBC. And in this person, probably also want to consider birth control because hydroxyurea could be teratogenic in case you decide to use it in a female that can get pregnant. So those would be just my 2 cents to add in there as far as, hydroxyurea is relatively easy to use and just need to watch out for some side effects and who you're giving it to.
That's what I wanted to ask you. So this is something that can be easily started without major workup or anything before?
You probably want to make sure they have sickle cell. So, one question I had is if you knew if she was like heterozygous or homozygous, if she'd had kind of the couple different tests you could do now, I guess, with electrophoresis or with probably genetic tests too. And so you'd want to make sure she actually has sickle cell, and would be something I would want to make sure I have information on before I would just start that medication. But other than that, if you think she's having a crisis, tough to say a little bit without being able to get labs, during her acute pain issues and having to send her to the ED. But if the ED seems to think that it's acute sickle cell, or you have a strong history, I think, and somebody hasn't started hydroxyurea for whatever issue, family dynamics, or can't afford, or maybe there's not a hematologist available for the person, hydroxyurea is pretty easy to start and monitor.
Okay, I'll have to look into that.
Any other recommendations from the group? Okay, so Dr. Harding, we will type up all these recommendations and send those over to you. Probably by the end of this week, you should have them. Thank you so much for presenting this case. It was a great case to discuss. We will now move on to the didactics portion of the session. I'll pull up the presentation from my side. We just finished this. This is a disclaimer slide. All of you have seen it. It just states that we do record our sessions. And if you don't want to be recorded, please send me a message on through the chat box, and we will be able to edit you out. And you did meet all our pain management hub team members. This is our disclosure policy, and this is the disclosure from our hub team members. And with that, I'll hand it over to Paul.
Hey, do I have control of this, or do I just say share screen?
No, next you'll have to, I'll advance the slides for you.
Okay, sounds good.
Yeah.
All right, so good to see you all today. And today we're going to talk about recognizing, diagnosing, and treating popular drugs. So this is a part one of a two-part series. When Dr. Harding is talking about her person who's coming through, it really hits me as somebody who needs to be heard, and a person who probably, or I would first go to trauma and trying to figure out what the fear, anxiety. I like that our specialist was talking about sleep disorders, but it's a opportunity to feel safe. And a lot of times trauma comes with powerlessness. And I think that's one of the things that's happening, especially with our younger people and all of these popular drugs that are available now. I have a picture of somebody on the internet, and, of course you can get things face to face. And then we have the isolation from the pandemic. So I think there's a lot of trauma that's happening, especially with the younger people. Go ahead, next slide. So what I really like about our team is Dr. Lewandowski has the 4 pillars to managing pain, and Dr. Patterson has the 5 key elements. And so I like to go through the 4 phases of change. I like to use the phases of change being, we want to recognize an issue, we want to acknowledge that issue, we want to understand the issue, and then we'll be able to make an educated decision about how we're going to change and how we're going to change for the better. So we're going to recognize and acknowledge popular and frequently used drugs, understand details and value of thorough diagnosis and evaluation, and review the stages of change and the appropriate level of care. So that was the objectives today and how I put this presentation together. We've had a lot of requests for these drugs, and topping them is Kratom, metrogeny. So we'll talk a little bit about Kratom. Opioids, from fentanyl to Imodium. Marijuana, when somebody says somebody's smoking marijuana, it's like, what kind? That goes between the moon and the bottom of the ocean. There's so many cannabis products out there. Right now, we're looking at a lot of Delta 8, and that's hemp derived. THCO is also hemp derived because there was a big push to make a lot of hemp. And now we have all this hemp and it really isn't selling a lot. So they're able to chemically alter it to make it a mind altering substance. And so we're seeing a lot more hemp type marijuana. Also, marijuana has a lot of, and cannabis has a lot of lacing that's going on. There's also vaping. And one of the things is somebody was going to be regulating tobacco for vaping. And so figured out a way to make synthetic tobacco so that it's not as, it can't be regulated until they get caught up with that new product. Acid, I'm seeing N-Bomb, which is a new acid product that has really diabolical outcomes. And you'll be able to spot that one pretty easily. And then of course, methamphetamine, which is just exploding everywhere. It's cheap, it's really potent, and it's highly addictive. So let's start with metrogenine or kratom. So kratom's interesting. It can act as a stimulant in lower doses or a sedative if it's taken in higher doses. So what is actually a lower dose and a higher dose? If you go into one of the head shops and ask them, they'll tell you something about maybe 50 milligrams, and that's the cutoff. It depends on who's selling it. And they're probably going to defer to your own personal experience, your weight, your gender, your activity level. They'll ask all kinds of questions like that, and really it's just kind of a guessing game. But it can lead to psychotic symptoms and psychological addiction. Low doses, it's like a stimulant. You get alertness, physical energy, talkativeness. High doses is more like an opioid, where it's going to be more sedating. The side effects: nausea, itching, sweating, dry mouth, constipation, increased urination, and loss of appetite. So along that opioid kind of side effect profile. Long-term users can experience anorexia, weight loss, insomnia, dry mouth, frequent urination, constipation. Kratom can be easily purchased, but it's no known medical usage in the United States. So when we're looking, if you want the sales kind of pitch there, and this is to understand it, that would be to go to the American Kratom Association. So these guys are organized. If you want to go to the FDA, they're not really behind it a lot. AMA is saying, as usual, we need more studies to back it. Go ahead, next slide. So deaths have occurred with kratom. But the thing with kratom is people don't just start off with kratom. They're usually taking other products, including opioids, benzos, alcohol, GABA, all over the counter medications like cough syrup. It's one of those add-ons that people will take kratom with. And so it's really unrealistic to think somebody just gets up in the morning and says, I'm going to really start hitting kratom hard and I'm going to use this drug until I overdose. It's usually something that's an add-on or available with other substances. There's no specific medical treatments for kratom. And some people found that kratom can actually be beneficial. So they're getting the results that they want. They're getting the feeling that they're after. Go ahead, next slide. This is another slide that shows how all of the other drugs come into this person's world or universe. Nearly all people who use heroin used at least 3 other drugs. So usually you have the usual suspects: alcohol, marijuana, cocaine is making a really big comeback. Now methamphetamine is really increasing in in usage, especially with younger people. And we have our opioid painkillers. So next slide. So when we're looking at Kratom, if somebody is coming in and they're talking to you and if they trust you and you want to find out what's in their system, many times they don't know what's in their system. So when we're doing drug screens, the drug screens are done for the patient, not to the patient. We're not judging, we're not looking at them as less than. We're looking at, okay, they're using this non-productive coping skill to cover up a lot of these, or the behaviors become symptoms, but they're covering up some core pain. And that's really what we want to get to. So in order to do drug screens correctly, you have to know the panels. Not all drug screens are created equal. And an instant drug screen or a dip is, to me, it's kind of worthless. It says that it has this substance in their system, but I want to know how much. I want to create a baseline. I want to find out exactly from a laboratory what is in this person's system. So I'm going to ask specifically the panels that I need for this lab. And then I'm also going to ask that they keep a sample so that if there's any questions or complications, that we can always rely back on that sample to make sure that the results are accurate. Because a lot of times people say, no, I didn't have any meth in my system or opioids in my system, but the marijuana they were smoking actually was laced with that. And so they're taking it, even though they don't recognize it, it's still in their system. And this is all vital information for helping this person. It'll also help us with the withdrawals that they could possibly be experiencing or going to experience. So we can predict a lot of the things that they're going to be going through, and we can help them on that road to recovery by paving this path for them. Go ahead, next slide. Okay, so actually we've been doing a pretty good job as physicians and other healthcare professionals. They've reduced opioid prescribing in every state for 10 consecutive years. They've increased the use of state prescription drug monitoring programs in every state for 5 years. Despite these efforts, drug-related mortality continues to rise. So at that level, if we're reducing opioid prescriptions and we're looking at the PDMP, this problem is more widespread than it used to be, because we've been doing this for over 10 years, and overdose deaths are now 94,000, which is a 30% increase from last year, which was also an increase. And these are record-breaking numbers of people who are dying of overdose. And remember, these are the numbers that are recorded or reported as an overdose death, which means there's many, many other deaths or people who have been brought back. They overdosed, but then they had their respiratory system kick-started back in, probably Narcan or whatever. But what about the repercussions with their life? How long does it take to have the brain without oxygen before you have some brain damage? So opioid prescriptions saw a 44.4% decrease since 2011. And the death total, 94,000, is provisional data for 12-month period from January 2020 to January 2021. And that's well in the pandemic. Okay, go ahead, next slide. Another chart. It's into 2021. Go ahead. It's just showing overdose deaths. Now, go ahead, next slide. That was March 8th, 2021, just showing that the trajectory is still going up. Overdose deaths from synthetic opioids, primarily fentanyl, and psychostimulants such as methamphetamine also increased in 2020 compared to 2019. Cocaine is making a comeback, and natural and semi-synthetic opioids, such as pain prescription medications, are all on the rise. So the pandemic, the isolation, the exposure, the availability, the accessibility, really all you need to do to get a lot of these products is go online. You can get a lot of this stuff delivered to your door and delivered quickly. Go ahead, next slide. Here's fentanyl. It's a little slide showing what it takes to overdose. And a lot of times with our first responders or emergency people, they're wearing gloves now to help pick people up off of the street or in emergency rooms or in emergency situations if they think that they're overdosing. And a lot of that is so that they don't get any of this potent drug on their skin, because once it gets into the skin, then their exposure to overdoses are really high. Go ahead, next slide. Imodium. So with the opioids, we've gone from, now that was fentanyl, okay? There's also carfentanil, which is 100 times stronger than fentanyl. It's an elephant tranquilizer, and that's out there too. So you can see that these products are getting really, really potent. Imodium, if you can't get that stuff, there's Imodium smoothies that you can make up. The idea with this is if you take it in high doses, then you can create euphoria. It kind of mimics the feeling of opioids. And what it does is, in the beginning, there's a barrier that you cannot pass until you overwhelm the opioid receptor, the mu receptors, and that's where the avalanche of this kind of product will create that euphoria. Unfortunately, there's cardiac adverse events, QRS widening, QTC prolongation, dysrhythmias. And so the answer there was, what we'll do then is we recognize that with Imodium, you can have abuse and misuse. And so we'll change the packaging. And now they only have a limit of 48 milligrams per box. But some of these people will buy 2 boxes or a dozen. And if they're ready to go to this extreme to get high, then this is what they'll do. Also, it helps withdrawals, because if they need to get those mu receptors filled so that they're not going through the withdrawals, then this is an option. 400 pills will cost you $15, and you can order it anywhere online. Go ahead, next slide. Narcan. Okay, we're running a little bit short of time. Let's see. During the COVID-19 pandemic, the number of individuals filling naloxone prescriptions from retail pharmacies decreased more than 26%. So maybe this is part of the package that we have to start. If we're having somebody exposed to opioids, then remember the Narcan. We have to start generating that back up again. Go ahead, next slide. Marijuana, cannabis, weed, hash, hemp, dope. We're looking at all kinds of stuff that's going on with marijuana now. So what I could do is go to the next slide. This is marijuana now. And so when people are talking about marijuana and they're asking, thinking that it was like back in the 60s, that's not what's going on right now. We're looking at things that will throw people into psychotic events. We're looking at 95% pure THC, which can throw the person into a psychotic event to the point where many of the ER physicians think that they're going through, that they're on meth, because they have 3 or 4 people strapping them down, and it's just wild. Also, I've worked with people after exposure to just marijuana, and they're not the same. And sometimes I don't know if they'll ever get their capacity back. But that's where we'll stop, and we can start off with that again next time, where we'll be going into diagnosing and evaluating. And I'll turn it back over to Sneha. And
yeah, that was great, Paul. Thank you so much. Any questions regarding the presentation?
I have a question, Mordechai here. When somebody tells you they are using Kratom, how does your counseling change, or is it very similar to most other opioid substances somebody might be using?
oh, that's good. Yeah. My first question is, what else? So yeah, I'm using Kratom. Oh, okay. What else? And then I want to find out why. So what's it do for you? How are you taking it? How long have you taken it? There's so many questions now that they've opened up. First, I want to thank them too, and let them know, hey, good. What do you want to do about it? Do you want to continue? Do you want to stop? Are you concerned about what it's doing to your body and brain? Where do you want to go? And then we start the conversation. But first, I want to thank them. Thanks for trusting me, and let's do this together. We'll go wherever we have to. Because usually when they're saying that, they're reaching out their hands, and I just feel like giving them a big hug.
Thank you.